wase walikuwa navuja, munipe dawa venye nataka hata za 1 year. Nimeona kwa news.
You don't wake up one morning because a new president has come in and then now with the executive order 28th of February now you are pulling out. That is also irresponsible. Donors also need to be responsible.
The notice had come at the first week of February. So there was a drastic drop in our retention, especially in February and March. A mother comes to the hospital, anauliza daktari, sasa niache kunyonyesha, unaona hiyo tension. Na utaacha kunyonyesha na saizo mtoto maybe ako 2 months old.
In December 2024, Kenya released its most optimistic HIV progress report in years. Infections down, deaths reduced, and more people than ever on treatment. But buried in the same report was a stark truth: a 12.8 billion shilling funding gap. The National Syndemic Disease Control Council has flagged this shortfall for years, yet it remains unclosed. A silent threat to the very progress that was being celebrated. 1 month later, in January 2025, a USAID stop work order sent the system crumbling. Patients panicked as facilities ran out of critical commodities, some for as long as 2 months. The shaky foundation on which Kenya's HIV care was built was exposed.
There was that news, it was written USAID RIP. Nauliza kama USAID ndio wameandika RIP, what about me? And an individual who is just there waiting for USAID to bring those things for me, at least to live a healthier life.
Vera was 17 when she lost her virginity and contracted HIV. Her story is that of a generation under siege. Young people who account for 39% of all new adult infections now facing even higher risk with key prevention programs abandoned.
There was this Dream Girls. They support young girls. They take you through school and do some short courses, which was also shut down early February. The community is afraid of maybe more infection.
The Dreams Project reached girls growing up in vulnerable communities, offering schooling support, HIV prevention, and safe spaces. It was one of the few interventions proven to keep adolescents, especially girls, from slipping through the cracks. Its closure leaves a critical gap at the very moment infections among young people remain high. For a decade, Kenya was hailed as a success story in HIV care. The 2024 World AIDS Day report credited this progress to a strong community approach.
Community engagement really entails identifying people at the community as champions, people who are on treatment, so that they explain to others the benefits of testing and the benefits of being on treatment. Simply because HIV is stigmatized. And you need a person who has walked the journey, who has braved the stigma and has gone to treatment, who can speak to others and convince them.
One of those champions is Sadiki. He tested positive for HIV 21 years ago. Today, he is virally suppressed and volunteers in Kilifi as a peer educator, helping others stay on treatment and live positively.
Katika hapa nilikuwa nahudumia wagonjwa kama 45 hivi ambao wako hii area. Ndio ulikuwa tuko nao. Halafu hao watoto ndio kwa katika ushirika lile lingine katika hii mambo ya watoto ile tungitegemea mambo nimekwambia. Nilikuwa na watoto wengi karibu ni kama watoto 60. Ndio kwa ni kushirikia. Jinsi tunavyowafundisha na vile tunavyofundishwa na vile tunavyofundisha na wao kule tunapotembea. Unakuta saa kidogo wengine wanakuwa na ufahamu na kuelewa. Unaona kwamba hii ni hali ya kawaida na inaweza ikampata mtu yote, ama hata kama wewe una, lakini katika upande wa jamii yako pia unaweza mmoja wao ama wawili wakawa wanaishi katika hiyo hiyo hali.
In 2021, we documented this success in Kilifi County. Selina Nyango worked in Ganze then, a village where poverty deepened vulnerability of people living with HIV.
I have around 67 children living with HIV, and among the 67, 19 as at July last year had a high viral load. All of the 19 children we've been able to visit them and outline barriers to adherence. After successful enhanced adherence counseling sessions with home visit, collaboration with Mwendo, support groups, enhanced adherence counseling, viremia clinic, all those combined, we were able to do a repeat viral load for the 19, and as at November last year, 18 of them had achieved viral suppression.
4 years later, Selina is now at Muyeye Health Center in Malindi. The setting has changed, but the results are strikingly familiar. She is still delivering wins against HIV, one patient at a time.
I think it's the 7th year I've worked with the HIV care and treatment, and in the facilities I have worked in, we get treatment completed outcomes. For the facilities I have worked in for the past 7 years, we've gotten negative outcomes. So this means that the mothers got good treatment literacy, they're there to treatment, the children got the prophylaxis, and they turn out negative at the outcome. I achieved 100% HIV suppression. By HIV, I mean children and adolescents living with HIV.
Beneath the seemingly smooth running of local clinics lies a system anxious about what happens when donor funding disappears entirely.
I have a 4-year-old girl and a 5-year-old boy who have very, very high viral load. And these are people who were initially on the OVC program that was supporting them come to their clinics. So there's the emergency fund for food, and there's transport to care money for them to come for their clinics. That was just cut. As we speak, they're not able to come to the facility.
When you used to be given 6-month drug, now I'm given 2 months or 1 month. Ndio tu itoshe kila mtu. So that is the trending in all facilities. Hakuna mwenye anapewa dawa more than 6 months.
There's a week in which now you go to a facility as a person living with HIV, and they ask you, do you know the treatment you are in? Because they didn't even have files. They had gone digital, and now the computer had collapsed because all of them were USAID. So how do you get into somebody's house and then you support everything, including the computer where they store data?
This is a collapse measured not in the missing files, but in missing priorities. How did a country that reduced HIV infections by 83% find itself unable to pay for basic drugs? In December 2024, the government admitted it was relying on overseas aid for 80% of the commodities needed to manage HIV. For every 10 shillings spent on HIV care in Kenya, the government puts in just 1. NGOs cover the rest. But overseas aid has fallen by more than half in the last 5 years. You'd expect the government to step up. Instead, funding rose by only 2% between 2019 and 2022. Here's what that looks like in real terms. For every dollar that USAID pulled out, the government of Kenya added just 6 cents.
Kenya responded to HIV by American government through PEPFAR or Global Fund. But even if we say Global Fund, 30% of Global Fund is American money. So these Americans have been communicating, but they're not very apparent. There's a way I can tell you to go, and I'll tell you, I don't want you here, go. The communication in Europe or America is such a way that you are supposed to use your brain, for lack of a better word, So unatumia akili, because these people since 2014 have been giving the signals that we are not here forever. What Trump did in February, the Global Fund is doing today, and it is not even in the media. They are also cutting, and they are saying we are going back to only this essential. Actually, for Kenya, they may only support procurement of ARVS, and it is not outside there.
As donors retreat, Kenya points to its own solution: integration. The idea is simple: merging HIV services into general healthcare, making it seamless and cost-effective. In Kilifi County, we observed this approach in practice, and it feels like placing an extra load on an already strained system.
So initially we used to have standalone comprehensive care clinics where the people living with HIV will go there for services. So we are merging that in routine care. Right now, we are at 65% integrated within Kilifi County. Yes, and we anticipate to increase that to 100% by the end of the year.
At the heart of the integration move is the financing problem. As it is today, HIV is almost non-existent in annual fiscal planning, and there doesn't seem to be an easy way to introduce it as an independent program.
The government is very clear. They are not in the business of talking about HIV funding or domestic finances for HIV. They will talk about domestic financing for health. HIV program to survive, it must get into the health.
Beneath the optimistic talk of integration lies harsh mathematics. 41,000 healthcare workers currently funded by USAID programs face unemployment as funding disappears. These are nurses, counselors, and community health workers who made Kenya's HIV success possible.
You see, like my children, because now my children, they are now my children, and I have 87 of them living with HIV. We make their clinic special. But now with the integration, I can't see them alone. With the integration, there's no clinician that will atakubali kuja weekend.
The major thing which will have given a shock or will have really affected us is the human resource who are being paid by USAID. There are quite a number of at least 120 staffs who are directly being paid by USAID. So I think that will be a gap.
Yes, I agree. It's unfair, but at the end of the day, these are resources that are coming from taxpayers of another country. So when they make that decision, we of course will lament, but the donor funding is at the discretion of the donor.
An uncomfortable question therefore arises: was this crisis inevitable or was it engineered? Some critics suggest the government allowed the system to unravel, betting that panic would force donors back. Others argue that the donors themselves sent signals for years, scaling down support while knowing Kenya was not ready to stand alone.
If you have invested for 20 years, and then when the 21st year you are pulling out, then everything crumbles. So that tells the US government that it was a bad investment. In 2024, we celebrated 20 years of PEPFAR in Kenya. Then in 2025, there's nothing to show that we have had PEPFAR for 20 years.
The real impact of donor withdrawal is latent, hidden beneath the surface of normalcy.
HIV is a latent virus. Even those who miss treatment, even those people who miss treatment today will not die. Even if they stop, maybe the earliest they can die is the end of 2026 or 2027. So government, the way they look at things is a crisis is death. So far, if you ask them the impact of Trump, they'll tell, but nobody has died. No, people are fine. But people are not fine because new infections are rising.
January I lost around 19 to follow up. Client amekataa tu kuja kuchukua dawa.
Community is also worried because when now, let me say there are no drugs, there are no ARVs, we will not be suppressed. Virusi zitaanza kuzaana, and then people do sex. You don't know whom you are doing sex with today is doing sex with another person tomorrow. So the community is worried in that there will be that spread, continuous spread of HIV.
For Vera, Sadiki, and the over 1 million Kenyans living with HIV, the shelf life of hope is measured not in years, but in the pills they can access, the clinics that remain open to them, and the political will to choose lives over ledgers.
The community will ask you, let me say, a friend maybe knows that you are HIV positive. They'll text you, ati umeona news, hivyo mtafanya aje? Mtafanya aje? I'm like, niko sawa, unaona? So the community perspective is also highly discouraging.
What we are not negotiating on is free access to ARVs. That one we continue to tell the government that it should continue to be free.
This year, Trump came and said, from today on, we are going to cut. Luckily, we still have the ARVs. But other things that need to go with ARVs are not there. So before you are put on ARVs, you need to be tested. Testing has collapsed in this country, and you can try in any facility. When you are tested positive, you need to go to the lab, and there are lab tests which need to be done. The lab tests include CD4, viral load, creatinine for the kidney, liver function test. So these days, because there is no money from Global Fund and PEPFAR, for those who go to pick their ARVs, they are told that you go to the pay private sector in the labs, and these people don't have money. People living with HIV deserve the quality of HIV care as outlined in the guidelines on minimum package of care, including quality laboratory services, not just the issuance of ARVs. People living with HIV need clarity. If it is the official policy of Kenya government to charge people living with HIV when seeking care, if so, can there be a waiver for the most vulnerable recipients of care? Work on the intimates, talk out of laboratory and diagnostic services that include HIV testing kits and reagents, viral load, especially now that we are going through problems with PPT tubes. You've just brought a few to the facilities, CD4 count machines.
Maisha yangu ninaishi kwa kutumia dawa. Sasa leo hii kama wewe utakatisha dawa, je, unataka mimi niishi vipi? Unataka niishi hapa duniani ama unataka nife tena? Maana sababu mimi bila dawa siwezi kutoboa. Mpaka nihakikishe kwamba asubuhi nimemeza dawa yangu, kesho nimemeza dawa yangu ambapo ni ARVS. Na hiyo yote ni wewe ndio ambapo ndio unanifanya mimi nipate hiyo huduma ya dawa. Na ndio unanifanya mpaka mimi nipate uzima. Na si mimi tu, ni janga la watu wengi. Sasa je, ukisema kwamba unakatisha ndugu yangu usipate huduma, watu wataka tutelekelea, wanataka tuwe vipi? Kama unatufikiria vipi sisi katika maisha yetu, sisi na familia zetu? Nataka tuendelee na maisha ama basi nataka tukatishe maisha? Maana sasa hakuna njia nyingine. Kwa mfano mimi nimeishi kwanza hiyo 2004 nimeishi kwa kutumia dawa mpaka kufikia hivi sasa. Na niko na familia zangu.
The question isn't whether Kenya can afford to maintain its HIV programs. No, it's whether Kenya can afford not to. And in the arithmetic of human survival, some calculations are too costly to get wrong.